Okay, guys, this is Dr. Ang back with you again. We're going to dive into muscular dystrophy now. So this is another video in our sequence of cerebral palsy, muscular dystrophy, and then multiple sclerosis that we'll hit in the final third video. But for muscular dystrophy, another disruption to activity and rest, focusing again on disruptions related to muscle disorder. So muscular dystrophy is, if you break it down again, remember I mentioned taking the words and breaking it down and kind of seeing what definition, and usually you can come pretty close to what this would be. So muscular, obviously muscles, and then dystrophy meaning the dys meaning bad, so dys part of it means bad, and then poorly, trophy, nourished muscles. So bad, either there's a defect or it's poorly nourished muscle fibers that are leading to this. Poorly nourished muscles due to a degeneration, which leads to ultimately the disorder, and the signs and symptoms that we see are associated with muscle weakness. Duchenne's muscular dystrophy is going to be the most common, and it's a rare genetic inherited disease defined by muscle weakness that gets worse over time. And then ultimately, it's just a slowly degeneration of the muscle fibers. And the sad part about this one, unlike cerebral palsy, muscular dystrophy, it does progress. It is progressive. Cerebral palsy, we mentioned, it's permanent but not progressive. But with muscular dystrophy, it is progressive. So that's going to be kind of a cardinal sign of how you're going to be able to tell the two apart. And it's going to continue to progress. And this is, MD is going to be a child that may, in all accounts, look there's not any abnormalities that are noted initially. And then as the sequence start coming, then you start to see a pattern. And as you track that pattern, they will start to actually degress, and that's what we're watching for with MD. But Duchenne's is obviously, there are different types. Duchenne's is the most common. So changes in the muscles themselves, but it's not necessarily in the nerve juncture, it's actually in the muscle fiber, and we'll dive into this a little bit more. But it occurs from a genetic mutation of the dystrophin gene. So it is genetic in about 2/3 of the case, but there's 1/3 of the case that's just a random dysfunction within the mutation of the gene. So 1/3 are not found to be genetic, but 2/3 are, and that's generally what we find out is a parent is either the carrier or they have it themselves. Okay. So if you follow along again with the PowerPoints, we'll kind of hit this. It is a genetic disorder. Generally, as we've said, it's a genetic disorder and it's an X-linked mutation. So what does that mean? We usually, if we're in class and I can get your feedback, what does it mean if it's an X-link mutation? That means that, so mom may be a carrier or a female may be the carrier. They are going to have, since the female will have 2 X chromosomes, they're going to be able to fall back because they have a backup. However, for the males, this is why it's more common in males, and you're generally going to see this. This is in males that you'll see muscular dystrophy because they don't have, so males have the X and the Y, they don't have a backup X. And since this is an X-linked mutation, if it occurs on the X, they don't have a backup. So you will see muscular dystrophy because it's, again, the dystrophin gene is X-linked. It's a gradual progression, degeneration of muscle fibers. So I draw this on the board generally, but I'm going to try to explain it to you here. If you want a deeper dive with this, please Zoom me. I find this kind of fascinating how this works. So the dystrophin is found on the X gene. All this goes into the effect of making the muscle fibers. So if you were to look at a muscle fiber, you would see kind of like a bigger tube with maybe a whole bunch of little straws poked in it. And that is going to be the myocytes, or the strands. So a whole bunch of just little strands of myocytes that make up the muscle. So when you flex, it's all those myocytes working together that can do the flexing and the relaxation, extending of the myocyte strands. Now, the damage comes when, as damage comes to the muscle fibers, calcium eventually will seep in, and then creatine kinase is going to seep out. Okay, as this occurs and damage occurs to these muscle fibers, over time, they can say, okay, we got this, we can repair, but then over time, it just becomes to eat away and be so much damage that they can no longer repair themselves. So then you start to get a weakening of those strands. And as that goes, it can be filled as the body's trying to, we're trying to repair itself. Your body's going to do all it can. And any injury you have, you'll have all hands on deck. We'll kind of go to that area. And as those fibers are weakening and pulling apart, and again, the calcium's going in and further damaging, and then the creatine kinase is coming out of the cells, that's a cardinal sign of how we diagnose this. And if you do a blood test, is there an increase in creatine kinase when you do that test? And then is there going to be an increase in calcium inside of those cells? And as they start to break apart, your body is going to start to formulate fat cells instead of the muscle to try to make up for that. That's how some of the cardinal signs that you'll see with muscular dystrophy are going to be enlarged calf muscles in different groups as they try to overcompensate. And it'll look like that it's a very muscular calf when really that is fat deposited, trying to recoup and repair, when really that fat is not going to serve the same purpose and for strength and stability that the muscle would. And again, this is primarily in males. Let's see. So the next slide, you'll see it's X-linked recessive disease, inheritance of Duchenne muscular dystrophy. You can see the chromosomes there and look to see how it can be passed down, and the mom can be carrier and then pass it to a son. And if the son actually has that Duchenne mutation of the Duchenne on the X-link, they're not going to have a backup for that. And then that son then would have muscular dystrophy. So the primary problem with MD is muscle weakness. Gower's sign is a cardinal sign, and often one of the very first signs that you see, or that parents will or caregivers will come in to the pediatrician. And I noticed when we were in preschool or whatever, I would see that Johnny would be on the ground playing with friends, and the other kids would kind of just hop up and run and play. But I would see him kind of scuff back and try to get onto his feet, and then demonstrate this a little bit, and get up and then kind of work their hands up their thighs to provide that support. And that getting up from using the hands and working their hands up their legs is not having the muscle strength that normally that they would have. That's that slow progression of muscle weakness. So that's the Gower sign. So know what that is, because it's a cardinal sign of muscular dystrophy. And then I was mentioning the enlarged calves. Pseudohypertrophy. That's where you think, and it looks like, wow, sweet, some very muscular calf muscles. And in essence, that's the fat being deposited where the loss of muscle is. And as those myocytes are, it's being damaged and they're no longer able to repair themselves, it's deposited with fat to try to give some stability. And obviously fat is not going to be able to perform the same role as muscles would. But pseudohypertrophy is the enlarged calf. arched back. This is another sign where you would see more standing in this pose. I don't know if you can, but it would be protruding out the abdomen and then offering support in their back. And again, these are just different ways that the individual would compensate for the loss of muscles, abdominal muscles. Again, every part of the body is comprised of muscle groups. So we need those for proper posture to carry ourselves with ease and in a safe manner. So as this goes, whether it's in the legs, whether it's in, that's the first thing we're going to see. And then you'll see a child that's running and playing. And then eventually they get to be 3, 4, 5, 6. And then you notice things are getting a little slower. Or they might be 7, 8, 9 and they're starting to fall or appear to be a little more clumsy. And it's that loss of muscle tone. And rather than getting stronger, they're actually going the reverse and getting weaker, which makes this an incredibly sad, and just it's a disorder and a disease process that's very difficult for caregivers, not to mention the patient, obviously, or the individual, but then the caregivers and everyone around, because you want to provide support. And as healthcare team, we want to come around and make things better. And really, we know the progression, not always, and because of research, things are on the horizon, making life expectancy to be longer than it once was. This is a disease and a disorder that would come where generally individuals could be in a wheelchair by their early 20s or by their teens, and they would not live past their 20s. And now this is a disorder that is bringing people up into their 30s, approaching their 30s and into their early 30s, which is just, it's fantastic. And that's why when we talk about research and all the efforts being made, why it's so critical that research is put in this effort, because we are actually seeing, and I have seen in my lifetime taking care of young men primarily, that I have seen that it has actually expanded their life expectancy, and that's amazing to see. As a healthcare worker and part of the healthcare worker team for pediatrics, to see that we're not only just getting them through their pediatric years, we're bringing them into young adulthood now. And we're seeing kids that didn't think they would maybe even graduate high school now are graduating with college degrees. And that's awesome. And what research has done. Distal muscles, foot dropping, tripping. This is seeing where, just again, as muscles, they're not picking up their feet. They're having foot drop. This is where we're going to see, in trying to compensate, going up on our toes and having that tiptoe effect that you'll see. And again, that's just the muscles, everything, or trying to use everything that they've got as it's getting weaker and weaker. And the more the myocytes are damaged and unable to prepare themselves, you can see how weak those muscles would get. And obviously with this, you're going to be able to hold up your skeletal structure on muscles like this. But then what do you do once it starts to get out like this? It's going to be a lot more atrophy occurring, and then accident prone as well, fall risks as well. We can see contractures, obviously, if they're falling, and then we don't have our muscles to be able to help catch ourselves or to help repair if there are injuries. So that's contractures. It can lead into scoliosis. A major cause of death, we think about this, if it's affecting all your muscle groups. We start with the legs, the arms, extremities, then it starts to come in a little closer. So what would you think would be the major causes of death? Then it's going to be, what other major muscle groups do we have? It's going to bring into your heart, your diaphragm, into your lungs. It starts affecting heart and respiratory failure. Cardiac arrest is going to be sadly the major cause of death for individuals with muscular dystrophy. So the types again, two types. Duchenne's, which is the most common, it's a dystrophin protein is absent. So if there's a mutation on that X chromosome, dystrophin gene is just completely absent. And it's diagnosed usually by age 10 and possibly even before. Now, Becker's is the second type of MD, and that is less common and it's less severe. The dystrophin gene, the difference between the two, the dystrophin gene it's present, but it's just mutated or it's malformed. So it's there, it's just not working properly. The diagnosis for Becker's is going to be a little older. So, 10 up into your teens usually, can be all the way up to 20 if it's less severe. So just know Duchenne's, no dystrophin gene, and it's diagnosed by 10. Then you have Becker's, less severe, diagnosed by 20. So diagnosed in the teens to 20, and the dystrophin gene is there. It's just going to be malformed or there's a further mutation there, but at least it is present. Okay, Duchenne's, again, most common, wasting and weakness is increased. Calf muscles, the hypertrophy is what we've mentioned of the calf muscles is the cardinal sign. Loss of independence and ambulation. This is the sad part here. I want you to kind of know the timeline. And again, because of research, this is expanding. So there's hope here. This sounds very doom and gloom, just to mention a kind of a timeline, because every individual is different. But just so you have some idea, there's usually a loss of independence. And remember, this can be someone that starts out running and playing little league and they're on youth football teams, they're whatever. It can seem pretty normal, whatever normal may be, but it can be very normal to a young boy, let's say, that has MD, may not realize it, as we said, because they may not be diagnosed till they're 8 to 10 years old. So they can have a very productive, they can be on teams, they can be playing different things, and that's almost what makes this so, I don't want to say sad, but actually it is kind of sad, because they know what that normal feel is, and then it slowly starts to begin being taken away from them as they slowly digress. So this can be someone with a very promising, very athletic, very star of the team, that once that muscular structure starts to waste away, it can be just where they feel like they're being robbed of what could have been an amazing talent as well. So there's all that psychosocial stuff to unpack too. And when are we saying that this is diagnosed? Boom, right in your teenage years. So that's where we need, as a healthcare team and caregivers, we wrap our arms around and we lock in step with those caregivers and with that client. And we say, how can we help this individual to maintain the most independence and the optimal outcomes? And we set goals out there, and we don't talk about the doom and gloom of what's coming, although that education is there. We need to, that's very real, and we don't want to keep that from them, but there is a timeline that for Duchenne's, we're going to be diagnosed. There's going to be a start to see a digression. We're going to see loss of independence and ambulation can be by 10 years. So they can be running 1 minute. Now we're needing to use maybe arm crutches just for a little support. Then you get the hang of that, and rather than, usually when you're on crutches or require something that, as a pediatric client, a lot of times, not always, but sometimes, that, well, once I heal and work with physical therapy, then I'm going to get off this and I'm going to be back to my norm, my personal norm. That's not the case with MD. So they get into their arm crutches maybe. Then next thing they know, they're 12, 13, and now they're requiring a full-on walker. They get tired very, very quickly. It's a lot more effort involved in just getting from point A to point B, things where they used to would run, and they take this all for granted, and they used to have such independence, and now they're requiring help. And especially for a young teen male, this can be very challenging. Now you're asking for help, or you're asking someone at school to help you carry your books to school as you try to utilize your walker, and you want to have that sense of normalcy. However, you're slowly losing your independence. So that's something to be aware of, the psychosocial aspect. Then it can be leading into a wheelchair by age 15. So what does this happen? What are we thinking with this? This is right as you're thinking about a 16-year-old that could soon be driving and having a whole nother level of independence. And rather than gaining independence, they're losing it. All voluntary muscles are involved. And as I've said, up until now, till recently, we're pushing up closer to 30, but there was a common thread that would experience death by age of 25, and again, due to cardiac or respiratory events. So there's another slide that you can look at, and you can see that I've already mentioned the X and Y chromosomes and how it can be passed by a carrier that's a mom. You can look at the percentage and see males versus females, 25% each way. You're not certain if you're having a girl or boy. You can see 50% chance for a boy to be affected, 50% chance for a girl to be a carrier. You can look and see this here. And again, things that we might see first that might put a alert sign would be difficult, maybe riding a bike, or they begin to fall or get very tired very quickly, but tripping and falling and just things that require balance, especially riding a bike, things like that, or activities that they've always loved to do. And then now all of a sudden you see a pretty quick digression of they're not able to keep that coordination and balance that they once had. Abnormal waddling or gait, this is just the compensating for different muscle groups, and they will compensate and do a masterful job at compensation for a while. And then as it digresses further and further, then ultimately then they do need help in order to stay safe. So problems changing positions, frequent falls. Again, know what the Gower sign is. Cardinal sign for muscular dystrophy is trying to get up off the floor. And that's if you have a client in, even as a school nurse, this may be something that you would see and help identify. If they're on the floor, or you see someone in a PE class and they're having difficulty getting up, and not even over to a wall, but they'll sit and try to get up and then just walk their hands up their thighs in order to get in an upright position, knowing that is critical for MD. So I do have a YouTube video on here. You can watch this one or watch anyone. And again, I say this, I'm going to harp on this every time. Listen to testimonials. Don't listen to as much to an expert, even what I'm telling you. This is things that I have learned and I have seen. I'm going off of expertise of caregivers that have a child or that care for someone on the front lines, boots on the ground, with someone with one of these muscular disorders, that I can know what is the real life effects of this and what helps and what do you see and what are the challenges that they face. But I do have a YouTube video here. Feel free to watch this one or find one of your own. Better yet, if you can find someone, or if you're in clinical, you're gonna clinicals we already done, pediatrics, but find someone if you have the privilege of doing an externship, whatever you're going to be doing, or as a new nurse here, just a few months. If you're in pediatrics or you're around, ask someone and educate yourself on these disorders. But you're going to see here too, you can see the posturing. Straight up normal, we don't see anything going on. Then as it goes, you're going to slowly see the droop back of the shoulders, and then the abdomen protrudes. And that is leading to then the arched back. And again, almost that pregnancy walk when you're just putting your hands behind, just kind of supporting, just as that balance is changing, is going to bring us into noticing the change in posture for MD. Next sign is going to actually show you the Gower sign. I want you to, I'm going to harp this in because this is the cardinal sign for diagnosing MD. But you can see it there starting on the ground, not able to just pop right up. but working the hands from the floor up the thighs in order to try to get upright. Then we're going to switch again to Becker's dystrophy, Duchenne's and Becker's again. I'm hitting this again. Duchenne's does not, it's absent. Dystrophin gene is absent. Becker's, it's there. It's just mutated, it's disfigured, it's malfunctioning, if you will, in Becker's. X-linked as well, dystrophin malformed. When do we diagnose this again? We're looking in our teens now. So Duchenne's, we'd have already had it diagnosed now. Once we hit 10 to 20s is we're going to find out for Becker's. And it's more mild. So it can be up till hitting 20 before that's diagnosed. Wasting of pelvic and shoulder muscles as well. Just slow progression. Nothing different as far as what you're going to see generally. Just as far as timing of it being diagnosed, and it's usually less severe. And the interesting thing with this is cardinal star by Becker dystrophy is they can somewhat have a normal lifestyle. And again, we always say things that are diagnosed early, you can usually help with interventions, but this, different than CP, this one is progressive. So it's going to, there's a natural progression that until we're expanding the life expectancy, but it still is, that's just the nature of this. The muscles are just beginning to weak and waste away. And once that happens and progresses to the heart, then that's going to be the cause of death. Spinal muscular atrophy. This is another type. You can look through this. Not going to be a ton on this, but I just want you to know there are a lot of different kinds. SMA, this is one to look through because you can see not only is there SMA, there's several types here, and you can look through and kind of read it through, but we're going to be focusing on Duchenne's because that's the most common. Just know there are a lot of other types, more specialty groups, and then they all have their own specific unique attributes, things that are going to make that disorder unique, but focus primarily on Duchenne's for purposes of this class. Okay, diagnoses of MD, suspected on the basis of clinical manifestations. And after our video to this point, what would those manifestations be? We're going to be looking for the Gower sign. We're going to be looking also for the pseudohypertrophy calf muscles, the bulging calves. We're going to look for the arched back and the abdomen protruding forward, hands back, but again, Gower sign typically. Bringing someone in that says, I don't know what's the matter. He's played basketball for several years, and now all of a sudden here he is 8 or 9 years old, and he's tripping and falling, and he seems to be losing his coordination. I'm not quite sure what's going on. He's sitting down in the pediatrician's office, and then he kind of struggles to get up and works himself up on his thighs, using his thighs to get up. Different things that you're going to note, clinical manifestations that are going to point to muscular dystrophy. We would be looking at DNA tests we can do, or the Western blot. What did I say is coming out of the cells that that we want in, but it's coming out of the muscular cells is going to be the creatine kinase. It's released from the muscles in large amounts in muscle disease and wasting. When the muscles are wasting and weakening, there's going to be large dumping of creatine kinase out so if we do a blood test, we're going to be able to see an increase in creatine kinase. Muscle biopsy will reveal the degeneration, so that's another way to diagnose. And then just the history of behaviors and symptoms as they go through the timeline for Johnny, then we're going to say, okay, this is the natural progression for MD. Complications, contractures. Again, if you're not using it, you lose it, like we say with everything. And if you're sitting now in a wheelchair, If we're not using, we want extensive physical therapy. We want to do everything that we can to promote optimal independence and optimal outcomes. Disuse, if we're not, it's going to have further atrophy, weakening and wasting. So we're trying to use them and encourage them to stimulate, and for a while they will continue to repair themselves. Weight gain, excess caloric intake, but now what are we doing? All of a sudden you get a teenage boy that's used to being increased appetite, all this, that's a growing boy, teenage years, and we're going to set him in a wheelchair where they're used to running and playing and all sorts of activity in their daily lives, and now they're going to sit sedentary. What do we tell every child, every adult? We say, don't have a sedentary lifestyle, and now we're going to park them in a wheelchair. So there can be weight gain, which, does that help a teenager already that's wanting that independence and wants to feel normal and not be set apart? That's another thing to help with the psychosocial dynamics of that. Cardiac and pulmonary, further on in the muscle disorder, further on in the diagnoses, we're going to want to have cardiac and pulmonary support as well. The good thing about this is when you have MD, you can still maintain. I mean, we've come so far with our school systems for everything. I mean, now it's like with MD, you're going to college or whatever, and accommodations are there to make sure that you can have that independence and you can seek optimal outcomes and have goals, and not only have goals and set them, but actually reach them. So that's the exciting thing for MD. So maybe a goal in treatment would be plan of care focuses on maintaining independence, functionality, and prevent complications. So what are the complications? If it's falls, one of the challenges that I've seen personally with MD is when you come to the point where they don't want to let go. I don't want to rely on crutches. I can get there myself. I will not have crutches, or I will not have a walker, and then a fall will take place. Or the dread is the time it comes, I'm not going to get in a wheelchair because I know when I do, I'll never get out. And that is incredibly overwhelming for a teenager, the caregivers, the healthcare team as well, because there are certain milestones. They're educated, they know the timeline, and they know if I give up my independence, it's kind of even like an aging adult. I'm not going to give up my car because once I do, I'll never be able to have that independence back. That's a little bit of how this feels, just from my interviewing and talking with young guys in particular with this. It's just that loss of independence is so incredibly hard. So give them, as that nurse, as that critical part of that healthcare team, find them things that they can have some independence on. You know, if it's with the phone, if it's getting to events, and just because you have the walker or the wheelchair, you go to that event, that school event. I mean, you set goals here as your sometimes there can be modifications for vehicles where they can still drive. It's like, yes, this is a hurdle. Yes, this is tough, but you know what? We're going to get around this, and we're going to work so we're not going to just hope and pray you can get to the end of high school. No, we're making plans for college, and keep that hope alive for that individual, because that can be so refreshing, because if we believe in them, they can believe in themselves. So keeping that hopeful spirit around them is going to be critical, but giving them opportunities to choose when they can. Would you prefer this, or would you prefer that? Do you want to go here, or would you rather go there? We are going to have a wheelchair, but we have some options. Like, you choose what it is. I'm similar to somebody choosing a car. Like, what would be best for you? What do you see yourself in? Would it be good to have a walker when you're at home, so you're still maintaining that, but just for safety? Would you rather have than a wheelchair when you go out? What would make it better for you? And giving them as much independence and fostering a spirit of independence as we can. Palliative, symptomatic, supportive, assist child, family in coping with progression. The fatal nature of the disease, as I already said. I will say that for purposes of education, I will not remind, as I'm caring for an individual with MD? Would you keep that up? That can be education with this is generally how it is, but we're going to be the exception, and you're going to go far beyond that because we're going to provide optimal care along the way. Braces, age, range of motion, physical therapy, occupational therapy, ortho procedures that you can do. There are things that sometimes can be done. Steroid treatments can be done. Genetic counseling, family counseling. I say this just because, not that you, if there's a chance, I wouldn't want to have this. That's a whole ethical thing, how people feel about that. To me, I mean, I have my specific feelings of it, and whatever my child has is what I want to embrace, and we're going to make the most of it. But you know, that is something to think about, just the genetic counseling of that, more or less just for education purposes so that you're aware. So you can see, just kind of recapping, the gene related to Duchenne's is on a short arm of the chromosome. Again, completely absent in Duchenne's. Becker's, it's there, just mutated. You don't need to dive too far into the slide here, but notice no stem cell research is being done. There are a lot of avenues coming in order to research. You can see, as I mentioned before, we've had there be so many fundraisers and different things that you can do, because if you've known someone with muscular dystrophy, and you can see, I know people personally now that I know that have lived further and have a lot of life left to go that we wouldn't have seen 10 years ago. So we are headed in the right direction with MD for sure. So diagnostic testing for MD typically includes EMG and muscle biopsy. So muscle biopsy, you're going to be looking to see if you can see the lesions there. The other is the type of muscular dystrophy where dystrophin gene is absent. So which one, Becker's or Duchenne's, which one is it absent? It's absent in Duchenne's. Identify 2 clinical signs for MD and then describe them. No 2 Gower sign, what does that look like? Hopefully you're answering this as we go here. Getting up off the floor, using your hands to walk up the legs in order to maintain, again, an upright posture. Pseudohypertrophy is the calves, swollen calves. And that pretty well sums up MD. And again, if you have any questions or want to take a little bit deeper dive, or know someone and you just kind of want to peel this onion open a little bit deeper, reach out to me. I would love to Zoom with you and we can dive a little deeper. But what I've just recapped for you is the need to know information for the exam. So for your final, and then the cardinal signs that you're almost guaranteed to see on the NCLEX. So that is muscular dystrophy. I'll be right back with multiple sclerosis.